What's up, guys? Today I wanted to talk about something that I think medical school could be teaching better, which is aortic dissection. So the reason this is important is if you miss an aortic dissection, someone dies. It's pretty cut and dry. So there's really no room for error. What we're going to be talking about is something called the IRAD data. So I wasn't aware of this, but it was a national registry of about 450 people, and they really got granular as far as what symptoms they had, what the x-ray showed, what the CT showed, what the outcome was. So this helps us kind of have a gold standard of what to do with the suspected aortic dissection. Just as a reminder, an aortic dissection is when you have a tear in the aorta around here. So you get a tear in the inner lining, and then the blood extravasates into the muscle. It compresses on the aorta, and eventually, if the dissection is ascending, then it will tamponade around the heart. And typically that's how you die. So let's see what med schools are teaching. And so I took this off Med Bullets, which is an excellent resource. The history here is a tearing chest pain. That's kind of what's emphasized. And classically, there's an anterior chest pain that radiates to the back. So you have chest pain, tearing in nature, radiating to the back.
No. Fatality.
And then what they love is that there's unequal blood pressure in the arms. Typically, this is described as about a 15 millimeters per mercury difference. You might have a pulse deficit. So for example, you could have a pulse in the right arm, but not on the left. And then you might have an aortic regurg murmur. So basically what we're going to learn by the end of this video is that almost none of this will help you make the diagnosis because it's just not sensitive enough. So this might be very specific. Like if you have all these things, you probably have aortic dissection, but this video is more about what to do when these signs are missing. And the long story short is you can't afford to miss this. So, yep. And then a little bit more on the imaging. So the litigation aspect of this, it's really going to hinge on, did you take a good history, and then did you obtain the right images? So classically what I learned in medical school is that on x-ray you'll have a widened mediastinum, and on CT that you'll have the dissection flap, the double lumen, all that stuff. Really there's only one thing you need to know, is that CT angio is the most accurate imaging test. You can't do anything with an x-ray. You need a CT. Another option, if they can't get a CT, is a TEE. But a transthoracic, when the probe is right here, not good enough. So long story short, you can't rule out a dissection on x-ray, and you need a CT. Now let's hop over to the actual IRAD paper and talk about it. It's pretty good.
I'm afraid, Dave.
Yeah, so we're looking at the IRAD data. This is the International Registry of Aortic Dissection. This was a paper in JAMA in about 2000. What they did is they looked at 464 patients, and then we're going to talk about some of the data here. So the mean age seen was about 63. What that means is with this standard deviation, you could have had anyone in their 30s or as old as in their late 90s. About 65% of people were male. So what that means is you need to be thinking about women with chest pain having dissection more in your differential. As far as the patient history, when we think about the man with high blood pressure, what I'm trying to get through here is that 1 in 4 patients did not have high blood pressure. You can't think someone with normal blood pressure in their 40s doesn't have a dissection. I know that's unfortunate because it means you need more CTs. If they had a prior aortic dissection, although I feel like that doesn't even need to be said, One thing that was interesting is someone who had a aortic valve replacement. That was, they were kind of at risk. And not seen as much, but if they had had cardiac surgery or been in the cath lab prior, it was something to think about. Now here's where I think the money is. About 25% of people did not have chest pain when they had an aortic dissection. And what that means for you is if you have someone with upper abdominal pain or back pain, you need to be thinking about this. Only 35% of people rated a posterior component to their chest pain. And then the things we learn in medical school as far as having pain that's sharp or tearing, as you can see here, only about half describe this kind of tearing sensation to the pain. So if you're using sharp, stabbing, tearing as a way to exclude dissection, it's just not good enough. Only 28% of people said their pain had a radiating component. So if you're looking for that pain going front to back, it's just not good enough. If you look at the vital signs that people presented with, about 35% had a normal blood pressure. So if you can kind of imagine that elevated blood pressure is a late finding in aortic dissection, I think this helps to make sense. Initially, when you have that intimal tear, it's not really going to read as elevated on a peripheral blood pressure cuff. The aortic regurg murmur, again, 70% of people didn't have it. Pulse deficit, I think this is so funny because you see it in boards. 85% of people didn't have it. Let's go back. And then really the most important thing to come away with is the radiography findings. So about 33%, or what would that be? About 40% did not have a widened mediastinum on chest x-ray. So that, that buzzword that you're looking for, it was missing in 4 out of 10 people. If you use just that as a way to, rule out a dissection, you're gonna miss it. EKG, again, not really something we look at too frequently. The most important thing is that people got a CT. Now, when you look at the outcomes, people who had a type A and were treated surgically, they had, a way better outcome than the people's, let me say that again. So the people who had surgery, they still died at a rate of 26%. The people who were treated medically, they died at a rate of 60%. So, do the surgery if you can get to it in time. So, let's put this all together. What do we really do with all this data? I think the most important thing is you're not just relying on history. You're not just relying on physical exam. You're not just relying on imaging. You need to put them all together in a cohesive manner. But trying to have a disease script for aortic dissection that involves just a 65-year-old male smoker with elevated blood pressure, you're really going to miss too many cases. If you suspect a dissection, you need to get a CT. That's really the end of story. What I'm going to talk about in the next video is how to use the RAD scoring to decide when you don't need a CT. So we'll get to that, and just as a heads up, it involves D-dimer, our favorite lab value.